Good evening,
Good
everyone.
evening.
Good
Good
evening.
evening, Dr. Alok.
Yeah,
Good
good
evening,
evening.
Dr. Alok. Welcome all to the wonderful early first trimester scan today comprehensive event. This event is specifically brought together for all of you to really give you a great insight into the learning for the basics to the advanced techniques that you need to really master. And there is a great deal of responsibility that each and everyone who's holding the transducer, as towards the baby, towards the mother, towards all their family, towards everybody, in doing a great deal of job. It's much more beyond dating. It's much more beyond simple anomaly. There is a lot of factors to be assessed as we will learn in the full comprehensive course. It's not just the images and the delivery, they are a requirement. However, Dr. Alok will beautifully and most humbly and wonderfully summarize all the cases, the images, the pathologies, as we will see now and in the sessions to come. So, welcome all. Thank you, Dr. Alok. Over to you. Thank you.
Yeah. Thank you. Good evening, everyone, and good evening, Dr. Alka. It's always a pleasure to be speaking on the platform provided by Mediflick. And I'm very glad that you are organizing this course on first trimester scans because this is something which is the need of the hour. Okay, because worldwide we are shifting the diagnosis, many diagnoses, not only the morphological abnormalities, but PIH, aneuploidy screening. Much of it is now shifted to the first trimester only. So everybody should be very conversant with the first trimester. And this is sort of a curtain raiser for the entire course. Okay, so we will be discussing about the essential images that have to be obtained during the first trimester during the NT scan. Plus, I will show some of the abnormalities that we can pick up when we are able to take good images. Okay, so but obviously we will not be dwelling much on the abnormalities because that are going to be covered during the course, various course. So so these are some of the images that have to be obtained during the NT scan. So one of the major uh, role of okay. So now the major role of ultrasound is to detect congenital malformations. Fortunately, these are not very common at birth, roughly around 3%. But during pregnancy, the incidence is nearly double. And these end up in abortions, premature deliveries, and perinatal morbidity, mortality. And many survivors, they suffer from disability and long-term sequelae. So we want to detect them prenatally because that helps in counseling the parents, genetic testing, management of the pregnancy, and making delivery decisions whether to continue, not to continue, which hospital to, deliver this baby in, whether this baby is going to require a lot of postnatal support or not. So all these things we expect from ultrasound to be done during the pregnancy. And traditionally, we've been doing screening for abnormalities during the anomaly scan at 18 to 22 weeks of gestation. But today, because of the advancement in our skills and technology of the ultrasound machines that has improved very significantly, we can see much of what we used to see at 18 to 22 weeks at 11 to 14 weeks at the time of the NT scan. So this entire course is, dedicated to detecting various kind of abnormalities at the time of NT scan. All right. So what is NT scan? It is one of the first trimester scans. So one is the dating scan, and then at 11 to 13 weeks, 6 days, we do an NT scan when the CRL is 45 millimeters to 84 millimeters. And we generally do it by a transabdominal route. But as soon as, in fact, this is my practice, as soon as I find something unusual, abnormal, or if I'm not able to acquire good planes on a transabdominal scan, I shift to a transvaginal scan, and which offers many, many advantages because now we are much closer to the baby and we are using a high frequency probe. But so we get very, very sharp images, very good images. But the only drawback is that the maneuverability is not that great, and we have to be very, very dependent on the baby so that it comes in proper position. Then we can acquire good images. So start with a transabdominal, shift to transvaginal whenever possible. All right. So the NT scan, basically, it was popularized by this gentleman, Professor Kypros Nicolaides, who pioneered this concept of NT. So he realized that we can screen, we can scan, and we can measure the nuchal translucency, and that correlates with the aneuploidies such as trisomy 21, 18, 13, etc., etc. So today, we do the first trimester combined screening by using maternal age history, then serum biochemistry, and the ultrasound markers, and then we run it through a risk calculation software. And when we do it well, we we detect more than 90% of cases with a very low false positive rate of 2.5%. But now we have a new kid on the block. Okay, so we have the cell-free DNA, which is actually very, very highly sensitive. It is more than 99% sensitive with a very low false positive rate of 0.1%. So the traditional role of NT scan, which was aneuploidy screening, is now fading away. In many countries, NIPT is the choice of test for aneuploidy screening, and the many countries, they are not doing NT scan at all. So what we need to do is we need to realize that an NT scan is not just about aneuploidy risk assessment. It tells us about the accurate dating, number of the fetuses. It is helpful in early anomaly detection and preeclampsia risk assessment. It also helpful in screening of placenta accreta and screening for vasa previa. What it probably does not do that well today is screening for preterm labor. So if you look closely, these are the big three. Okay, big four, I can say: preterm labor, the preeclampsia, anomalies, and aneuploidies. These are the big four, and we can pretty much do a very good job detecting all these three, and fairly okay job if we screen for preterm labor by cervical length at the time of NT scan. So NT scan is much beyond the aneuploidy. This is the gist. So why NT scan became so successful? Because Professor Kipros spent a lot of time standardizing the test. So before NT scan, everybody used to do ultrasound in their own different way. So naturally, then the results would not tally that, everywhere. But Kipros Tincloides, he made sure that we have to acquire a certain image with certain parameters, and that led to standardization, and that led to, good results. And this is pretty much what we need to do when we are doing our morphological screening, because when we follow a standardized anatomic protocol, this is the most crucial factor which improves the sensitivity for screening of abnormalities. So we need to follow guidelines, protocol, and checklist. These are some of the guidelines that are used commonly. This is the World Association of Perinatal Medicine and the ISUOG and AIUM practice guidelines. So what we need to do is we need to measure the baby, we need to do the biometry, we need to assess the morphology, and then we need to assess the environment of the baby. And if we do it properly with standard planes, with standard images, then we are going to detect a lot of abnormalities. So this is the WAPM guideline. You can download it from the net. It's freely available, and it tells you about the various organ systems that have to be covered. But for beginners, at least, I think ISUOG guidelines is better because it tells us about 2 levels of screening. So somebody who's just starting, then they can simply do the minimum requirements and perform a basic structural survey. But I think whosoever is attending this course, is aiming to be a specialist. No, they are already postgraduates or having done diplomas or some fellowships, etc., etc. So we have to be aiming for the best practice. We have to do a comprehensive, detailed examination. So these are the structures which we need to cover if we are doing a minimum requirement. So just these 10 images have to be acquired. So this is basically a protocol-based approach in which you acquire these images. And if something is wrong, then you just simply refer the patient to somebody who can do a comprehensive evaluation. Okay, so these are the 10 images that is required. So the requirement is not very great. You just need to confirm there's a singleton pregnancy in the head. You need to take an axial view of the head and see if the bones are present, the two halves are separated by the interhemispheric fissure, and etc. etc. Then you take an NT scan, measure the NT image, and measure the NT. And in the heart, only 4-chamber view needs to be taken. In the abdomen, make sure that the stomach is visible, bladder is visible, and in the extremities, all 4 limbs should be visible, with each with 3 parts. Assess the placenta, just make sure it is homogeneous without any cystic spaces. And then we need to just do a biometry, which is CRL. And nowadays in the current guideline, the bioparietal diameter is also included in the guidelines. So these are the biometric measurements that have to be done. Now, the advanced level or the best practice is basically a comprehensive examination. So it does not deal with images per se, standard images per se, but what it wants us to do is it wants us to do a comprehensive examination of the organ system. So for example, let's say in head, we can take many sections which tells, we have to evaluate the calcification, we have to evaluate the contour and shape, the two halves separated by the interhemispheric fissure, etc., etc. But we also have to evaluate the cerebral peduncles, aqueduct of Sylvius, intracranial translucency, and cisterna magna, all in the first trimester. Similarly, for the heart, let's say, we have to establish the situs, we have to establish the position, the size, 4-chamber view, LVOT, 3-vessel trachea view, and we have to do a tricuspid regurgitation, measure the tricuspid regurgitation and BV flows. So basically, whatever we are supposed to do in the second trimester, we are doing in the first trimester according to the guideline. And this is sort of set of representative images that if we require, I believe they will cover whatever the guidelines are saying that we need to assess. Okay, so we will discuss these images in detail. All right, so the first and the foremost image that we have to acquire is a mid-sagittal plane. This is the most important image that we have to acquire, and we use it not only to assess the CRL, that is the crown rump length, but we will also use it to assess the morphology of the fetus. It gives us a good overview how the fetus is appearing, is it single, multiple, etc., etc. So all these can be assessed if we acquire a good mid-sagittal plane. So the fetus preferably should be oriented horizontally, 90 degrees to the beam, and that's when you get a good image like this in a neutral position, which means it should be neither flexed or hyperextended, which means that should be some sliver of fluid underneath the chin of the fetus, between the chin and the chest. And very, very important that it has to be magnified image. It has to be sufficiently magnified. That's when we are going to see the structures. So CRL is what is measured. We measure the CRL very, very accurately because this is the reference measurement for whatever tests which we are going to do, like NT or mean uterine artery PI or the biochemical markers for the double marker test. So CRL is the parameter that is used, not the LMP, etc., etc. So we make sure that we get a good image and then we measure the CRL accurately. So this is a sort of a good image. This is fine, but make sure that you do not have a fetus who's flexed. So here, notice that there is no fluid between the chin and the chest. So that is why the baby is flexed. So you will get a measurement on the lower side. Here we have an improper magnification, and here we have the fetus in extension. The neck is, it is hyperextended. So we see a lot of fluid underneath the chest. So this again is going to make the measurement unreliable. So this is the image to aim for. You have to be patient so that you get this kind of an image, and that's when you are going to get a good measurement. So that's the mid-sagittal plane. We are also going to use to assess morphology. So we know how the baby appears. Uh, so it has a particular shape. So the head is rounded. Then we have the neck and the body. And we cannot see the limbs because this is the mid-sagittal plane. All right. So, and immediately, like for example, this is an 11 weeks fetus. And as I try to acquire the mid-sagittal plane, immediately I see something is amiss. The head, which is supposed to be of rounded shape, it is not rounded at all. It is very, very irregular. So I know something is wrong. And when we do a 3D, it tells me that, yes, the head has lost its rounded contour. It is very irregular in shape. And we are going to discuss all these abnormalities during the course. But this is simply acrania exencephaly. Another case in which, again, if you are conversant with how normal looks, and this is decidedly abnormal, we see the head is irregular, the neck is hyperextended. This is anencephaly, a diagnosis which can be very, very easily made in the first trimester. And here, when I'm trying to make a good CRL image, I do not see the lower half of the body of the baby, of the fetus, and that is because much of it is, the baby has a kyphoscoliosis, it is bent, and some part of the baby is the abdominal visceral structures such as liver, the bowel. They are herniated outside the body wall. They are actually herniated outside the amniotic cavity. And this is the amniotic membrane that we are seeing. And all these structures are in the chorionic space. Then this is simply a body stock anomaly. So these gross abnormalities can be picked up very easily. And this one is again is as soon as I'm taking the CRL plane, I see something protruding out in the region of the umbilicus, and this one contained the liver, the bowel, and the stomach as well. And we see there is insertion of the cord on the top of this bulge on the top of this mass. So we know this is a large omphalocele. One more case in which we see in the mid-sagittal plane, the bladder is very, very distended. It should not be that much distended. This is more than 7 millimeters. This is 12.8 millimeters in size. So we know this is megacystis. So all these conditions can be simply diagnosed simply when we are paying attention to the CRL plane. And here in this case, there is no abnormality per se, but we see the disproportion between the head size and the size of the body of the baby. The abdomen is very, very small compared to the head. And this means that the fetus is suffering from an early onset fetal growth restriction, which is a sign of aneuploidy and particularly triploidy. So all these features can be, diagnosed if we are looking at this mid-sagittal plane carefully. The next image that we have to acquire is the axial view of the head. And the guidelines suggest that we start with a transthalamic plane. So that's the transthalamic plane that we need to see. This is an axial section of the brain. It should have a symmetric appearance at the level of the thalami. So these are the thalami, and we need to see the thalami. And we use this to measure the biparietal diameter, the head circumference, and to assess the morphology of the brain. Now, for biparietal diameter, there are two techniques of measurement. One is outer to inner, and second is outer to outer. So because the head size is small, sometimes outer to outer measurement is preferred, but make sure that you're using the correct nomogram if you're using outer to outer measurement for biparietal diameter. Now, head circumference is simple. We simply trace along the outer margin of the skull vault. You can use the ellipse cursor. You can use the trace cursor. Simply exclude the skull, the scalp, and trace along the outer margin, and that's when you're going to get head circumference. But once you've done that, be sure that you know the anatomy of the transthalamic plane. So these are the two lateral ventricles. These are the choroid plexuses. In between, there's a falx cerebri dividing the brain into two halves. Here we have the two thalami. These are the cerebral peduncles, and in between the cerebral peduncles, we see a small cystic space like this. That's the aqueduct of Sylvius. The third ventricle is visible in this plane. It is very small, it's very thin, and that's the third ventricle. And also notice that this cerebral peduncle, the midbrain, it is at certain distance from the occipital bone. So this distance is very, very significant, and we are going to see why. So we need to assess that the skull bones should be visible. So these are the frontal bones, the parietal bones. They should be visible in this plane. The contour of and the shape of the head should be normal, and there should not be any skull defect, and aqueduct and the midbrain should be away from the occipital bone. And these are the typical defects we can pick up if we are paying attention to the transthalamic plane. And this we immediately see there's a defect in the occipital region, something protruding out. So that's an encephalocele, occipital encephalocele. And here we see that the cerebral peduncles, the midbrain, it is actually touching the occipital bone. Here you can see that it is at some distance away from the occipital bone. Here it has sort of crashed into the occipital bone. So that's known as the crash sign. And we know this sign is representative of, there is supposed to be a CSF leak somewhere either from the brain or from the spine. And most commonly, we see open spina bifida, which is causing the crash sign. Then the third plane that we need to see is the transventricular plane. So transventricular plane is another axial section of the brain. Again, the head should have a symmetrical appearance, and we take it at the level of the lateral ventricles. We can use this to measure the biparietal diameter and head circumference if we are using only this plane, but a transthalamic plane is preferred for measuring the biparietal diameter and head circumference. But what we can use this plane better is to assess the morphology. So this is a very important plane because here again we will assess the ossification of the skull bones. We will see the contour and shape of the head. The two brain halves, they are separated by a interhemispheric fish forks, which runs from anterior to posterior. And we see this butterfly sign because we have the two choroid plexuses which are arranged. They appear like a butterfly on the sides of the forks. And the choroid plexuses, they are filling the lateral ventricles in the posterior two-thirds. Anteriorly, there can be some space in the frontal region, but in posteriorly and on lateral aspects, there is usually not much space around the choroid plexuses. So obviously, when we are conversant with an image such as this one is very, very unusual, abnormal, and very striking to the eye because this one lacks the interhemispheric fissure. This one lacks the typical butterfly sign. What we are seeing is a monoventricle. What we are seeing is a choroid plexus is, they are continuing from one side to the other. And this is a very typical appearance of a lobar holoprosencephaly, something which should always be picked up in the first trimester. Now, this one here, we can see that the ventricles, they are dilated, and we see a lot of space around the ventricles anteriorly, on the laterally and posteriorly as well. Now, this is ventriculomegaly. So in first trimester, we do not have the criteria of 10 millimeters to diagnose ventriculomegaly. So what we have to have a visual impression of how these choroid plexuses, are they filling up the ventricles or not? So if we see a lot of space around the around the choroid plexuses, that is suggestive of ventriculomegaly. And this is actually very rare in the first trimester. And if we see ventriculomegaly, we have to look for posterior fossa malformations. Aqueduct stenosis is most of the times, it will appear in the third trimester, but spina bifida is one of the causes of ventriculomegaly. And there can also be chromosomal disorders, genetic syndromes, vascular events, and infection, which can be causing ventriculomegaly. Then the next section which we need to take the third section of the brain. That is, we need to acquire a section through the posterior fossa. Now we can call it transcerebellar plane, but actually at the time of first trimester, the cerebellum is hardly developed. So what we need to do is we need to take a section, in the basal part of the brain. So that will take us through the posterior fossa. So again, axial section, it should have a symmetric appearance through the posterior fossa. And this is the anatomy that has to be, remembered. This here are the choroid plexuses, the horizontal limbs of the choroid plexuses. Anterior to it is the fourth ventricle, or which is also known as the intracranial translucency. And posteriorly, again, there's a space which is the future cisterna magna. And somewhere anteriorly here is the developing cerebellum, which is, not very well developed at the time of the NT scan. So the recent papers have stressed on this entity known as the choroid bar, which is nothing but the choroid plexus of the fourth ventricle. This is an echogenic line seen in the posterior fossa. And as shown earlier, anterior to it is the fourth ventricle, posterior to it is the future cisterna magna. And when we do not see the choroid bar, like in this case, if it is totally obliterated, we do not see the CSF on both sides. This usually means there's a CSF leak somewhere, and usually we see in cases of open spina bifida. Then sometimes we do not see the choroid bar because there is a posterior fossa cystic space which is dilated, and this we need to follow these cases up. Some of them, they turn out to be black spot cyst. Some of them, they will turn out to have Dandy-Walker malformation. And these can be distinguished by the position of the fourth ventricular choroid plexuses. And I think this will be covered during the talks on the CNS. Then we come to the very, very important plane, that is the NT plane or the mid-sagittal plane, which delineates the head and neck of the fetus. And that's the plane that we use not only to measure the NT, but we also assess it to the presence of the nasal bone. And then we also look at, very, very carefully these days for the various abnormalities. So morphological assessment is very important. Now, this plane has to be acquired in a perfect position. The baby has to be in a horizontal position. And again, the baby should have a neutral position. The neck should not be hyperextended or flexed. Again, we should have a small pocket of fluid over here underneath the chest, underneath the chin and the chest. And very important part is proper magnification. The head and thorax should be occupying the whole of the screen. So very important. So we need to confirm that it's a perfect mid-sagittal plane. If we see the echogenic tip of the nose, the palate should appear rectangular shaped, and we should be seeing the translucent diencephalon over here. If we do not see the tip of the nose, or if we do not see, the palate is not rectangular, or if we are seeing some echogenic structure over here, that's the frontal process of the maxilla. Sometimes we see, or we see choroid plexuses over here, the ventricles. That means, of course, we are not in the proper mid-sagittal plane. So we should try getting a proper image like this, and that's when the measurement are going to be proper. And for regarding the NT, again, this will be covered in the talks, but we need to see where we need to place the caliber. We need to measure the widest part of the nuchal translucency from inner to inner, and we need to distinguish between the skin, that's the skin, and the amnion. So that's about the nuchal translucency. And we know the nuchal translucency, we are not relying on a particular value these days. We calculate the percentile, but if the NT figure is more than 3.5 millimeters, that is considered as 99 centile for any gestational age, and abnormal NT is more than 95th percentile for a CRL. So we measure the NT and then we go through the nomograms, and that calculates the percentile value. So that's about the nuchal translucency. But we know that the increased NT is not only associated with aneuploidies, but it is again a marker for congenital heart defects, genetic syndromes, skeletal dysplasia, some connective tissue disorders, but in many cases, the baby will turn out to be normal. So important that we evaluate. We do not abort these babies. We do further testing, and if depending on the testing, we counsel the parents. So not only the aneuploidy, we have to be aware about the morphology. So these are the various anatomic structures that we can identify. We can identify the tip of the nose, the nasal bone, that's the palate, the mandible, and that's the forks, the echogenic forks, because we are not seeing the ventricles or the choroid plexus is here. This is the thalamus or the diencephalon. That hypoechoic structure is the brainstem, and posterior to it is the fourth ventricle, and behind this is the cisterna magna, and this is the nuchal translucency, as everybody is aware. So if we have a fetus which appears like this, the face is definitely abnormal. We are not seeing any nose. It is appearing very, very flat. And then we do a 3D, we find that the nose is absent. We see a midline cleft over here. We know this is really abnormal. This is arrhythmia, and typically we see this picture in cases of lobar holoprosencephaly. Now, fetal palate can be evaluated in this plane, and in the palate, this is the palate, and it is composed of the two bones, overlapping bones. The one is the vomer, and second is the palatine process of the maxilla from each side, and these sort of overlap with each other, and these are continuous. They sometimes have a very small gap over here, but usually it is less than 1.5 millimeters in size. And because the two bones are overlapping, we call this as a superimposed line sign. Again, we're talking about these signs in the talk on the first trimester fetal face evaluation. So if we see that this palate, like here, you can see that the palate is appearing interrupted anteriorly, and instead of two bones, we are seeing just single bone over here. So there's a maxillary gap and there is an absent superimposed line sign. We know this baby is going to have a cleft lip and palate. So not very easy to diagnose in the first trimester, but if we pay attention to these signs, if we have a good image, then we can identify that the baby has a cleft lip and palate. And this one, you can see this is how the normal profile appears. And here we can see that this profile is not that normal. Okay, in the first look, it may appear to be normal, but then we realize that the chin is falling behind. So if we draw a line along the forehead of the fetus, you will see that it touches the chin. But if we draw a line along the forehead in this fetus, we see that the mandible is receding, and this is a sign that the fetus may be having micrognathia. Okay, so micrognathia. So again, micrognathia is a syndromic condition in many cases, and the fetus has to be evaluated, fetus has to be followed up, and we have to look for other abnormalities. But much attention is now given to measurement of intracranial translucency. So that's the intracranial translucency. This part is the intracranial translucency. This is just basically a fancy name for the fourth ventricle. So these are the three spaces that we see. This is the brainstem, the fourth ventricle, and the cisterna magna. And when there is a abnormality, when there's a leak of the CSF, then the CSF drains out and this sort of drags the brainstem downwards, and the intracranial translucency that gets lost. So we see this kind of an appearance, only two lines and two spaces. So normally we are supposed to see three spaces and three lines. So that's the brainstem. This is the interface between the brainstem and the fourth ventricle. And this is the fourth ventricle choroid plexus, which is separating the fourth ventricle from the cisterna magna. So 3 lines and 3 spaces should be seen. But in case of open spina bifida, we see 2 lines and 2 spaces. So when we see this loss of intracranial translucency, we need to scan the spine carefully. And in some cases, in many cases, we are going to find a defect such as this. So there's a curvature abnormality. We see there's a defect of the posterior elements over here. Now notice how subtle the defect is. It is, otherwise will be very difficult to pick up if we are just scanning the spine. But fortunately, we have intracranial signs which tell us that there's an open spina bifida. Now, face, we can attempt to assess the fetal phase by doing these coronal planes. So one is the retronasal triangle. So that's the coronal section of the anterior part of the face. It is a complete bony triangle with no gaps. And we can also acquire a plane which delineate the orbits. So the orbits, they should be 2 equal-sized anechoic spaces. And if possible, we can also look for the lenses, which, we can see as dots in the orbits. Now, routinely, we do not look for the upper lips because theirs are very, very thin, though the current guidelines, they say that we have to look for the lips, but in my experience, very, very tough to assess the upper lip. So we have to rely on the bony defects in the retronasal triangle or the maxillary gap or the superimposed line sign if we want to detect the cleft lip palates. Again, we do not take axial planes of the palate or the mandible when we are doing a NT scan. So we have to do these corneal sections, the retronasal triangle and the orbits. So that's the retronasal triangle. So this is formed by the frontal process of the maxilla on both sides, the nasal bone at the apex, the 2 nasal bones, and this is the alveolar process of the maxilla. So this should form a continuous triangle. And these are the various abnormalities that we can see. So here we have the apex of the triangle is lost. So this is due to absence of the nasal bone. Here the base has a defect because this was a case of cleft lip and palate. And here we do not see this typical mandibular gap. So that's the gap we see in the retronasal triangle plane, a gap between the 2 mandible rami. And if we do not see a gap like this in the proper retronasal triangle view, we need to suspect that this baby may be having micrognathia. Now, we have covered the head, we have covered the face. Now we go to the chest. So in the chest, these are the 4 sections that we are supposed to take. We can also add an LVOT view in this scheme of things, and that will also make the examination more comprehensive. But I think if you take these 4 planes well, there is no particular need to take the LVOT view or RVOT view in the first trimester. These are anyways very difficult to acquire in the first trimester. So that's the 4-chamber view in grayscale. And then we need to take it in color. We have to demonstrate the 2 atrioventricular stripes. Then that's the 3-vessel trachea view in the grayscale. This again will be difficult to acquire grayscale, but what we need to do is we need to turn on the Doppler and demonstrate this V. And this V sign or the tick sign is very important parameter to be assessed in the first trimester. So if we have at least these two images, the 2 AV stripes, the tick sign, we know many of the gross abnormalities of the heart can be detected. So this is a checklist that we need to follow. We need to see the shape of the chest wall, the lung fields. We have to see the diaphragmatic continuity, though the guidelines, they just show us the axial planes. So to assess the diaphragmatic continuity, I suppose that we need to acquire the coronal or sagittal planes. We need to establish the situs. We need to assess the cardiac axis, the size, 4-chamber view with 2 distinct ventricles on grayscale and color, LVOT view, 3-vessel trachea view in grayscale or color Doppler, and make sure that there is no tricuspid regurgitation and the DV flow is normal. And this is few examples I would like to show. So here, the cardiac axis is the heart is rotated leftward, so there's levo rotation, and that is a clue that there may be a conotruncal abnormality. And sure enough, in the 5-chamber view, we can see there's a ventricular septal defect with overriding aorta, and that's the pulmonary artery that is joining the aorta at an angle, and it is appearing very narrow in caliber, but it's showing forward flow. Okay, and also we notice that the V is forming on the right side of the spine. So that's the spine, and it is forming on the right side of the spine. So this is basically a case of tetralogy of Fallot with right-sided aortic arch. And you can see that this was diagnosed at 13 weeks, 3 days of gestation. So the starting point was that the heart appeared to be deviated, it appeared to be rotated. So that's the starting point in many, many cases. Here we can see that the 4-chamber view is abnormal. There is severe chamber asymmetry. That's the right side. This is the left side. And we can see that the left-sided ventricle is, it's barely visible. Nothing can be seen. And when we turn on the Doppler, we can see that there is only one atrioventricular stripe like this. No flow is seen across this valve, the second AV valve, the mitral valve. And when we do the 3-vessel trachea view, we can see that the aortic arch, it is showing reversal of the flow. That means the mitral valve is atretic, the aortic valve is also atretic. So we know this is a hypoplastic left heart syndrome, right? Okay, hypoplastic left heart syndrome. And these are some of other cases. If we pay attention to the 4-chamber view, we can identify these abnormalities. This is, we see that the atrial septum is quite deficient. We do not see the crux over here, linear insertion of the valve. So that's a AVSD at 12 weeks of gestation. Here, we do not see the interventricular septum at all, but we see the 2 AV valves. So the 2 atria, they are draining into a common ventricles. That's a case of double inlet left ventricle. So all of these, both these cases, they were diagnosed around 12 weeks of gestation. Okay, so I think the other heart abnormalities, they will be picked, they will be discussed in great detail by Dr. Shilpa in her talk. So let's leave some for her. For the abdomen, the minimum requirement is that we take an axial view in which the stomach should be visible, and we make sure that the abdominal wall is intact, or the bladder should also be visible, and it should not be dilated. So for that, we can take an axial or selective view. But for the detailed view, we need to take these 6 planes. Perhaps we may omit this because this one shows the genitalia in the Indian scenario because of the PNDT Act. I think this should be skipped. But we need to demonstrate the stomach should be in the normal position in the left upper abdomen. Bladder should be normally filled in the pelvis, and it should be less than 7 millimeters in diameter. The abdominal wall should be intact. The cord insertion should be normal. We should be seeing the 2 umbilical arteries bordering the bladder. This can be sometimes difficult to demonstrate, but if your machine has, slow flow capability, slow flow can demonstrate this very, very nicely. And we also should practice demonstrating the kidneys either on axial plane, but in my experience, the coronal plane to demonstrate both kidneys, it works out better. In axial plane, it is difficult to identify the kidneys. All right, so this is the first plane which we need to see. This is an axial section of the upper abdomen. Again, it should have a symmetrical appearance at the level of the stomach. And we use it to measure the abdominal circumference, to check for the situs and assess the morphology. So very important that we make sure that the stomach bubble is visible, because if it is not visible, for example, here in this case, we need to locate where the stomach bubble is. And then we see that the stomach is, it has gone inside the chest, which is deviating, which is pushing the heart towards the right side. That is because the baby has a left-sided congenital diaphragmatic hernia. Just one example. Now we go to the mid-abdomen. We acquire a plane at the level of the umbilical cord. So that's the umbilical cord inserting into the abdomen. And we see umbilical cord insertion. We see any abdominal wall defect if it is there. And we can also use it to assess for any echogenic bowel. So this again is a very typical example. We see something protruding from the abdominal wall and in the region of the umbilicus. And this is the case we've already seen, omphalocele, which can be very easily picked up in the sagittal plane when we are taking the CRL easily. But something like this will be difficult to pick up when we are taking the CRL plane, the sagittal plane. So this is again an axial plane at the level of the umbilicus. We see just a small protrusion in the base of the umbilical cord. These are the small bowel loops which are protruding at the base. So, and notice that the gestational age is less than 12 weeks of gestation. Okay, so let's not call this omphalocele at present. So we need to wait for, at least 12 weeks. So call this fetus, call this baby, sorry, this pregnant patient again, and then reassess. And if it is still persisting, maybe it's a small omphalocele, but most of the times it is going to regress, and this is nothing but the physiological herniation of bowel. So the take-home point here is do not be in a hurry to make a diagnosis, especially in the first trimester, because there are certain physiological changes which are happening. So in case of any doubt, it's always prudent to call the patient back again after 2 weeks or 4 weeks and then reassess. Then we take another axial section in the lower abdomen at the level of the urinary bladder, and we check this section for the urinary bladder, and it should have the two umbilical arteries on each side. And we can sometimes make a diagnosis of single umbilical artery in the first trimester, but if we are doing the imaging correctly, but even if you, let's say, not uh, make a diagnosis of single umbilical artery in the first trimester, I don't think that is, something unusual. What we should not be doing is making a false diagnosing of single umbilical artery, because the umbilical arteries at this stage, they have a very low flow. So you have to work really hard on getting a good plane like this. And then your image setting should be good. The PRF should be quite low before you can say safely that this is a single umbilical artery. In most of the cases, the cases which get referred to me for with a diagnosis of single umbilical artery in the first trimester, majority of them, they actually turn out to have the two umbilical arteries. Now, for fetal kidneys, as I said, coronal section is better. We acquire a section like this. The kidneys, they appear echogenic in the first trimester. This is nothing unusual. This is normal. Should not be misdiagnosed as a renal medical disease or something. Uh, we can demonstrate the two renal arteries arising from the aorta if we are using a power Doppler or HD flow, or even better, the slow flow. So this is another way of distinguishing the kidneys in the abdomen. So we should be seeing the two echogenic kidneys, and we can sometimes even assess the spine, the coronal plane of the spine in the same plane. So the kidney renal abnormalities in the first trimester, they are very hard to pick up. But if we pay attention, sometimes we can pick abnormalities such as this. So this was a case in which you can see that the left-sided kidney appears present. It is appearing normal, but nothing can be seen on the right side. And then we could not see any kidney elsewhere in the abdomen as well. That's the urinary bladder that is present. And when we turn on the Doppler, we can see there's only one renal artery arising from the aorta. On the other side, we do not see any renal artery. So this kidney turned out to be an absent right kidney. So if we see just one kidney, most of the cases they will have an ectopic other kidney, but this one was a non-visualized right kidney. Now, this is in fact even rarer. we do not see both of the kidneys. We do not see both of the kidneys. We do not see the urinary bladder, but notice the amniotic fluid in this case, it was okay, it was normal. And when we, try to locate the renal arteries, we do not see the renal arteries on each side. Okay, so both the renal arteries, they are absent. These are the lying down adrenals on both sides of the spine. Notice the gestational age. This is just 13 weeks of gestation on which the bilateral renal agenesis was suspected. So we, called the patient back at 16 weeks, and by that time we could see the signs, proper signs, the typical signs, severe oligohydramnios, the kidneys were not visible, and then a final diagnosis of bilateral renal agenesis could be made. So remember that amniotic fluid is normal in the first trimester because the kidneys, they start producing majority of the amniotic fluid by 16 weeks onwards. So if we are paying attention to the kidneys, then we can perhaps pick up this kind of an abnormality. Now, spine, try to see when this baby is dorso-anterior, that means the back is up, and the spine should have a regular shape and it should be continuous. There should not be any dorsal cyst or masses, should not be any bending or kyphoscoliosis. So some typical abnormalities that, very, very easy to see are like this. So there is kyphosis. Here we have an acute angulation of the spine. So that's the gibbous formation. So not very difficult to uh, identify, but if you are not seeing the spine at all, then of course you are going to miss these kind of abnormalities. Then very important that we see all the four limbs. So both hands, both upper limbs, both lower limbs should be documented, and all three segments of all the limbs should be visible. So we should be seeing the hand, the forearm, and the arm. And here we should be seeing the thigh, the leg, and the foot. So all two upper limbs, two lower limbs, three segments in each limbs, including the hands and feet. There should be active limb movements. The long bone should be, straight. They should have the regular proportion. There should not be any bending or rotation. Finger counting, some people, they find it easy to count the fingers in the first trimester because the hand is usually open at this stage, but this is something which is optional. Okay, so what we should not be missing is a case like this, in which both the forearms and the hands, they are absent. Look at, see, that's the forearm, this is the arm, it is visible. So all these, limb reduction defect should not be missed. Here we have a single lower limb, the other limb is absent. And this was a case of caudal regression syndrome. So that at 13 weeks of gestation should not be missed. Now, this one can be difficult to identify, but if we are paying attention that we are demonstrating all the three segments, then we can pick this up. This is absence of one hand, achiria. So the arm is there, the forearm is there, but the hand is absent. And this one is club hand, very easy to spot. The hand is abnormally angulated over here. The radius in the ulna, they are not very easy. They are difficult to see in this case. Polydactyly, sometimes, yes, if we get lucky, then we can identify polydactyly. This one was at 11 weeks of gestation. This was a case of actually a twin pregnancy, but somehow could see that there was, multiple digits. So 7 digits instead of 5. But I think even if you miss polydactyly in the first trimester, I do not think that's a crime. So these are not very easy to diagnose. So there are certain abnormalities which should always be detected, so anencephaly, inencephaly, omphalocele like this, the large ones, the gastroschisis, alobar hollow pores encephaly, body stalk abnormality, megacystis, and major limb reduction defects, they should always be detected in the first trimester. And that is why it is very important that we take standard planes, we, evaluate the fetus morphology completely. We can also, do refine the first trimester combined screening. So instead of not only doing the NT, we can also add the nasal bone. I think not going to spend much time on nasal bone. So the section which is required is the mid-sagittal head and neck plane. The nasal tip should be visible, and that's when we see the two lines over here. That's the skin, that's the nasal bone. And when we do not see the nasal bone separately, we call it as absent. So here, notice that we are not measuring the nasal bone. We are just simply documenting whether it is present or not. And this is something which is present in 2% of the euploid fetuses, but in trisomy 21 cases, the incidence is higher. And if we scan the baby at the earlier gestation age, roughly around between 11 to 12 weeks, the incidence of absence of nasal bone is much higher. Remember that absent nasal bone is not an indication of termination of pregnancy. This is simply a marker, a soft marker, not a very good marker at that. I think all these fetuses, they should be evaluated further. NIPT is a very, very good method to confirm if there's something wrong or not. Then we can also use the heart rate, the ductus venosus flow, and tricuspid flow for refining the aneuploidy risk. So DV, mid-sagittal plane, we turn on the Doppler, magnify the image, and then we need to reduce the PRF. Sample gate should be kept as low as possible, 0.5 to 1 millimeters. It should place it in the area of aliasing over here. So that's the bright appearing area over here. And try to avoid contamination from the adjacent veins. Keep the wall filter low and keep the sweep speed high, and you should see this sawtooth-like appearance in the waveform, and that's the SD and A waves, a typical waveform of the ductus venosus. And when we see something like this, that is reversal of the A wave, this tells us there's an increased risk of chromosomal abnormality, cardiac defects, and even fetal death. In many cases, the reversal of the A wave, the pregnancy outcome is going to be normal, but we need to rule out aneuploidy, and we need to do a comprehensive fetal heart evaluation to make sure the heart is normal. For the tricuspid flow, again, we need to magnify quite a bit. We take the 4-chamber view and magnify. We place a sample gate across the tricuspid valve. It should be a wide sample gate, 2 to 3 millimeters in diameter. And again, we keep the sweep speed high, 2 to 3 centimeters per second. And we should be getting a waveform like this. And if we are seeing something like this, leaking in the systole. So if the regurgitation is lasting half of the systole, at least half of the systole, and the velocity is more than 60 centimeters per second, that's when we diagnose tricuspid regurgitation. So important that we place the cursor the gate properly across the tricuspid valve. It should be a wide gate. And again, tricuspid regurgitation can be present in normal fetuses as well. So again, the DV flow, abnormal DV flow, tricuspid flow, they should not be indicators for termination of pregnancy. Simply, they mean that we need to evaluate these fetuses. These days, we are not using frontomaxillary facial angle for aneuploidy risk assessment. Neither we use the aberrant right subclavian artery for aneuploidy risk assessment as of now, but we are gathering data about URSA in the first trimester. So soon, maybe, I do not know when, this also may be added to the list of the things that we need to do. Then we assess the uterine environment, the fetal environment. For that, we need to assess the placenta. We need to see the placental morphology. It should be of homogeneous ecotexture. If there's a history of previous LSCS scar, then we need to see whether it is on the anterior wall or on the posterior wall, or is it covering the internal os, cover in the lower segment or not. Because if it is in the lower segment along the anterior wall, there's a high risk of placenta accreta spectrum. Now, cord insertion should be assessed in the first trimester. It is easier to assess cord insertion into the placenta at the time of first trimester than later on. So just turn on the Doppler and trace the umbilical cord and see where it is inserting into the placenta. There should not be any retroplacental or subchorionic clot. There should not be any cyst or any lacunae. So we can have morphological abnormalities like this. That's the rolled up edges of the placenta, circumvallate placenta. Again, much easier to see in the first trimester than in second or third trimester, because in the second or third trimester, the placenta stretches and we lose this rolled up edge appearance of the circumvallate placenta. Here we have a subchorionic hematoma, again identifiable in the first trimester. Now here the placenta has a lot of cystic spaces like this. So this usually, if the baby, the fetus is abnormal, it has morphological gross abnormalities, this is a sign of partial molar pregnancy. Or if the baby is normal, then it can be a sign of placental mesenchymal dysplasia. Now, something like this, vasa previa, this can be identified in the first trimester quite easily if we are paying attention to where the cord is inserting. So very important diagnosis to make in the first trimester. I think it is easier to make in the first trimester than in the second and the third, because relatively the fetus is small and it is quite mobile, so we can trace the umbilical cord very easily. Cervical length screening for preterm birth, it is something which we do, preferably through a transvaginal route. If there's any history of a preterm labor, preterm birth in the previous pregnancy, or if there is, history of multiple abortions, then that patient is at risk of preterm labor. Cutoff is 25 millimeters as in the second trimester. But even when we find that the cervical length is less, the studies, they have not proven the measuring of the cervix is, it improves the outcome. But if we see something like this, that is obviously the cause of concern, and the obstetrician, they are going to, put a cerclage over the cervix or put the patient on progesterone treatment. We can screen for preeclampsia in the first trimester. Very nice method. We need to identify the uterine arteries near the uterocervical junction on both sides. Do the pulse wave Doppler. If the PSV should be more than 60 centimeters per second, that shows that we are in the uterine artery. We need to measure the PI of both uterine arteries and calculate the mean pulsatility index. And then we run it through the algorithm, and then we get the risk of preeclampsia. Notching like this is normal in the first trimester. This is of no significance in the first trimester. And as I said, we combine various parameters, the maternal factors, history, biochemistry, then mean arterial pressure on both sides, and the uterine artery Doppler. We run it through a risk calculation software, and then we calculate what is the risk of preeclampsia. So this was all about singleton pregnancy. When we have twin pregnancy, the most important thing to document in a twin pregnancy at the 11 to 14 week scan is whether the pregnancy is monochorionic or a dichorionic. So if we see two separate placentas, in most of the cases, it is a dichorionic twin pregnancy, but some papers, they say that, one paper says that 3% of the monochorionic twins, they can have two placental masses on ultrasound. So technically, this is not a reliable method of, distinguishing monochorionic from a dichorionic twin pregnancy. So when we have a single placenta, sometimes you can get confused whether it's a monochorionic or dichorionic twin pregnancy. We need to check the intertwin membrane, whether it is present or absent. Look at the base of the intertwin membrane and check the thickness. So the best sign to distinguish between a monochorionic and a dichorionic pregnancy is if you are able to demonstrate twin peak sign or a lambda sign. So what is twin peak sign? We see this invagination of the placental tissue at the base of the separating membrane between the two twins, and this forms a triangle like this, and that's the lambda sign. Very important sign to demonstrate in the first trimester, because less than 14 weeks, it is 100% accurate. But as the pregnancy advances, this sign loses its accuracy. So by 20 weeks of gestation, it is only 80% accurate. That means in 20% of the cases, this sign will not be able to demonstrate. And when the membrane inserts directly onto the placenta without any uh, this lambda sign, uh, at 90 degrees like this, that's a T sign. This is a sign of monochorionic twin pregnancy. If you're not able to see any intervening membrane, best thing is to do a transvaginal scan and demonstrate there are no intervening membrane, and we see the intertwined fetal parts. We see the umbilical cords, they're entangled like this, and this is a monoamniotic twin pregnancy. So whenever we are not able to demonstrate the intertwined membrane, best to do a TVS and see for sure. So to summarize, we need to do a systematic examination with a standard protocol to improve detection of various abnormalities. We need to practice taking standard views. If we develop a muscle memory, then we realize that, let's say, for example, if I want to take an NT image, if we should not be happy by taking just like any NT image. It should be perfect, and that's when we are going to get good results. We have to be methodical. We need to use a checklist. It's an examination that requires a lot of patience. We have to wait for the optimal position of the baby for good planes. Start with a transabdominal scan because that is easy. If any suspicion of abnormality, switch to a TVS. And as soon as possible, everybody should be shifting from minimum requirement to best practice, because that's the way we can diagnose a lot of abnormalities. Thank you so much.
We have some questions, sir.
Yeah, sure.
If the ductus venosus PI is 1.2,
Yes.
sir, this is the question only.
Okay, let me just see where the questions are. Just let
In
me
the
stop
Q&A box.
sharing. Stop sharing. Yeah. Chat.
No, sir,
All
in
right.
the Q&A box.
Yeah.
Above mentioned,
Q&A.
sir.
Yes, yes, yes.
Above mentioned.
There. So my laptop, I'm just rebooting, but yes,
Yeah.
there are 4 questions on Q&A that I could see then. So let's just look at those. Thank you. Pooja, if you can ask the questions, thank you.
Yeah.
Yes, ma'am.
Thank you.
So one question is, if the ductus venosus is PI is 1.2, so we used to, there was a time when we were measuring the PI. Again, we can calculate the percentile value for PI, the nomograms are given. And if it is more than 95 centile, then we consider it as abnormal. But in practice, actually, it is easier. We just simply look for the A wave reversal. Okay. If we are looking for the A wave reversal, that's a more comfortable sign. That is, because I am not very comfortable measuring the PI of the ductus venosus in the first trimester, because there are a lot of variables over there in the first trimester. If it is reversing, then I know for sure that it is wrong. It is not, a normal thing. So I think, especially for the beginners, I would suggest that, leave the PI out of it and simply see the A wave reversal. Okay, so the question was that the DVPI is more than 95 centile, but the NT and cardiac status are normal, then how to follow? So as I said, that in many of these cases, these babies, they are going to turn out to be normal. Okay, so what we need to do is we need to follow these cases up, and in most of the cases by 14 weeks, 16 weeks, that even the DV, it turns to be normal. Okay, so if the heart is normal, NT is normal, generally I would simply wait. All right, so the next question is, can we diagnose vasa previa in the first trimester? I showed you a case. Yes, we can diagnose vasa previa in the first trimester. That is there. Simply, we need to follow the umbilical cord insertion into the placenta, and sometimes if it is inserting onto the internal os, or if it is inserting close to the internal os, we can do a TVS examination, and that can tell us whether there's a vasa previa. Of course, these cases, they have to be followed up and confirmed in the second trimester, because the vessels, sort of move as the uterus grows. So the next question which I am seeing is the normal choroid bar sign again. Okay, so anonymous attendee, you need to wait. Okay, this will be covered comprehensively when we are doing the proper course. This was just an appetizer for you. I'm glad that you are having all these queries, because I hope you will be attending the course, and then we can delve all these in great detail. All right. The other question which I am seeing is elastography in the assessment of preterm labor, and color Doppler setting to see SMA for diaphragmatic hernia. Okay, so elastography I do not use in the first trimester. It is something which is, there are a lot of papers available on use of elastography, but it has not become mainstream per se. So as of now, we are not going to deal with it. The other part was SMA in the first trimester. So SMA is something which it's a additional sign. When we have, in my experience, when we have already documented there's a diaphragmatic hernia, then we can use an additional sign such as SMA, upturned SMA, to, further corroborate our findings. Sometimes it can be useful if, the stomach is inside the abdomen, but only the bowel loops, they have herniated. We need to keep the PRF, the wall filters, as low as possible during our machines, but I find it much easier in my machine that I just simply turn on the slow flow, and it works like a wonder. You can see every small vessel that can be seen in the first trimester also. All right, so the next question is what to do if there's a reversal of A wave at 12 weeks. So as I said, we need to evaluate the fetus comprehensively. We need to look for increase in the NT. If we need to look at the heart, if there is any gross malformation, and we need to look for other signs of aneuploidy and other malformations, structural malformations. If I do not see any of these, then I simply wait. I do not even actually sometimes do further testing. I simply wait, call the patient back at 14 weeks, and majority of the times the DV has come back to normal. If it is still not normal, then yes, I would investigate the fetus for any aneuploidy or any other malformation. If we see an abnormality on the NT scan indicative aneuploidy exam, thickened NT, would you prefer an immediate CVS, or is it better to do an early anomaly scan with amniocentesis if needed? Oh, this is not an easy question to answer. All right, because it depends on case to case. It's not something we can make a guideline on it, because it depends on what other abnormalities are you seeing, how wide, how thick is the NT. If let's say if it is a borderline NT, then I would simply wait till 16 weeks, do an amnio after doing a comprehensive evaluation of the fetus. But if it is slightly thicker NT, then I would simply do a transvaginal ultrasound of the fetus and look for any cardiac abnormalities. If I do not see cardiac abnormality, we will discuss this with the parents. And if they are keen to get the answers fast, then we'll do a CVS. What we will not do in these cases, we will not do a NIPT. Because once we find that the NT is high, if it is more than 95th centile or more than 99th centile, that is an indication for invasive testing. Then the need for screening tests such as NIPT, that is not there. Okay. All right. So which chart to follow for uterine artery Doppler? Okay. So which chart to follow? You can use the FMF charts for uterine artery Doppler. They are very nice, and that gives us the risk assessment for uterine artery Dopplers. Barcelona also gives the uterine artery Doppler, but the risk calculation that is done through the FMF software. So I think that will be better. FMF software, if you use that, will be better. Now, okay, so the Dr. Shrikant is asking, does the echogenic line at IT, the breach is due to the Blake spout cyst? Yes, it is due to the Blake spout cyst in the midline. I'm glad you asked this because this is something which is normal, and we are going to cover this when we are covering the CNS abnormalities in the first trimester. If the NT is around 3.5 and the CRL is low, it is 40 millimeters, how to proceed? Okay, so this is becoming common actually, that when we are doing a scan at, let's say, 10 weeks of gestation and we find that the NT is high. All right, so in my opinion, we simply wait. Do not be rash, do not be in a hurry, because many of these babies, they will either perish by the time of NT scan. If they are gross abnormalities, many of these cases, they actually have Turner syndrome. So if in such cases, they will either perish, but if they are surviving till 12 weeks of gestation, and if we find that the NT is still high, then yes, we are going to proceed as we do for high NT in the first trimester at the time of NT scan. Now, there was a paper very recently in which they said that if the NT has resolved by the time of NT scan, in such cases, the risk of aneuploidy, the risk of genetic abnormality, it reduces, but it does not become zero. Okay, so we are in a gray zone over here. But in my personal opinion, if I find NT is high, whatever the gestational age, that is a high risk, should be evaluated comprehensively.
Thank you. I'll take the next question. If BB is absent in 11 to 13 weeks, is there any need to follow up scan?
BB, I hope they're saying nasal bone.
Yeah, I think they
probably.
meant nasal bone. Yeah, NB.
Yeah,
I thought
so
bladder bubble. I thought, was it bladder bubble or what? I don't
I
know.
don't know.
Okay. Anyways,
Hopefully
we'll
nasal bone.
please log in. Hopefully, yeah. How to differentiate? So, do we need to follow up? Yeah.
Yes, I think we should
Yes.
follow up. Okay, but
And
anyways, it's suppose it's a minor marker in my opinion. The nasal bone absence in the first trimester, very, very common. Very gives a lot of false positive. I do not, pay much emphasis. It's just it's an indicator that there may be something wrong. So I would evaluate that fetus more comprehensively, look at the heart, look at the other structures. If I find something unusual, that's when we'll go to invasive testing. But in most cases these days, we simply offer an IPT, and nearly always it turns out to be normal.
Okay, so the next question, Dr. Shamil Patel is asking how to differentiate local extrophy from bladder extrophy in first trimester. So today's session was about the basic images, but still you've gone way beyond. And I would really thank you for your inquisitiveness and do register. You will definitely get all your answers. And sir, how accurate is increased PI if you try artery in the first trimester in predicting preeclampsia IUGR in the future? Dr. Shilpa Satarkar is going to cover
Yes.
this topic beautifully and wonderfully for all of you. I would say do register, and more radiologists or whosoever is scanning, please get on with this. This is very basic, very simple, and it really has long lasting outcomes on maternal health and overall health of everybody. Thank you. How long to wait if we don't get perfect mid-sagittal section for NT? Are there any ways to improve? Your
Yes.
expert opinions.
Yes. So uh, it depends. It depends basically how patient you are and how many people are screaming, outside, how full your OPD is. So we would try to get as perfect plane as possible. One of the ways to improve is that you can ask the patient to fill up her bladder just a little bit, uh, partially full bladder, and try again. But in my practice, what we do is, if I'm scanning and if I'm not getting a good plane, if I find that the baby is vertically inclined or oblique, then I do not waste much time. I try to assess whatever structures I can, and I simply ask the patient to wait. Okay, call the patient back after 10-15 minutes. Most of the times, in 80-90% of the times, the baby is in a decent position. But what you need to stress to the patient is that this is normal. Okay, the patients, they get apprehensive because they feel that this is something wrong with the baby, something is unusual. So you need to talk to the parents, and you need to tell them this is how life is. The babies, they do not oblige. You need to do it.
Thank you. So, till what gestational age can we suggest NIPT?
NIPT can be suggested at whatever gestation is. There's no, the lower limit is 10 weeks. There is no upper limit per se, but in general, we would not go beyond the second trimester for suggesting NIPT.
Okay. Next is what screening test to suggest if absent NB in first trimester and normal in T?
Yeah, so as I told you, the opinion may be divided. Some people may offer invasive testing in such cases, but in general, I think more and more people are shifting towards NIPT when you find an isolated absent nasal bone in the first trimester, not any other sign. So the NT is normal, the other, the whole risk calculation is normal, only the nasal bone is absent. So in those cases, I think NIPT will answer.
Thank you. So the last question by Dr. Shrikant is, if there's subtle reduction in distance between the fourth ventricle to occipital bone and the spine is normal, but there is no obvious crash car sign, is there anything else to look for close spinal bifida?
Okay, so one thing we need to see is that in the early part of gestation, somewhere around 11 weeks, 3 days, 4 days, the midbrain is actually very close to the occipital bone. That distance only happens because the cerebellum starts developing. Okay, so if you are scanning early in the pregnancy, you will see something like that. So do not mistake that for a crash sign. Okay, so need to follow these cases up. And if you're saying that there's no obvious crash sign, the spine looks normal, again, simply follow these cases up. There's no need for making a diagnosis of spina bifida or closed spina bifida at the time of 12 weeks. This examination is like a bonus examination. Okay, we do not have to make every diagnosis then and there. Actually, if our attitude is that we are going to make every rare diagnosis in the first trimester, we will end up making a lot of false diagnoses. So we have to be very careful.
There are two questions for again, what next? I would really say next is you register and you will really
Yes.
get all your answers for what next. That's beyond the scope of this talk, however, absent NB in anomaly scan, and if increased cases of NT, what do you suggest? That's a total case on, that's the whole concept of this
Yes.
whole course, that we need to know if we find something, what next and how to go about it. So I invite and welcome you all to join Dr. Jiten, Dr. Alok, Dr. Shilpa Satarkar for a very fabulous, exciting, great learning. Thank you so much, everyone, for joining in. Thank you, Dr. Alok, for all your
Thank
great
you.
time. Thank you. Thank you so much. Thank you. Thank you
Thank
so
you.
much.
Thank you so much. Good night, everyone.
Thank you.
Thank you,
Thank you so
sir.
much.
Thank you, ma'am. Participants, kindly fill the feedback form we have shared in the chat link for better sessions in the future.
Thank you, Dr. Alok. We have lots of appreciations for you. Super fabulous talk as always. So many appreciations in the chat, so many appreciations in the Q&A that were there in between all the questions. So thank you so much for an always amazing session and amazing images and great delivery. Thank you so much. Thank
Thank
you.
you, Dr. Alka. Okay, so I'll take your leave. I'll say good night.
Thank
Good
you.
night, everyone.
Thank you.
Thank you.
Thank you so much.